Let's hear from you. And again, different substance, different population. Amanda Miller is a current T32 trainee on the same program that Cherie was on. And so she's also going to talk about another part of biobehavioral research on HIV. So go ahead, Amanda.
Thank you so much, Pamina. Good morning, everybody. As Pamina said, my name is Amanda Miller, and I'm a current postdoc in the Department of Epidemiology. And today I'm here to talk to you about alcohol use and associated HIV risks in pregnant women in Cape Town. This work was undertaken with colleagues at the University of California, Los Angeles, as well as at the University of Cape Town. And we will be looking at data from PrEP-PP, which is it stands for pre-exposure prophylaxis in the pregnancy and postpartum period. So alcohol use and HIV are prevalent public health issues in South Africa. They're also interrelated health issues, and they can lead to adverse health outcomes for both mother and fetus. South Africa experiences exceedingly high rates of fetal alcohol syndrome. In fact, it experiences the highest rates in the world. In addition, HIV prevalence in this setting among pregnant women is very high at 29%. Therefore, addressing these issues is critical to HIV prevention efforts, as well as the promotion of healthy pregnancies and births. To better understand the relationship between alcohol use and other HIV sexual risk factors, we examined associations between these measures among a sample of pregnant women in Cape Town, South Africa. Baseline data from PrEP-PP was analyzed. PrEP-PP is a prospective observational cohort study of HIV uninfected pregnant women attending antenatal care in Gugulethu Township, which is located directly outside of Cape Town, South Africa. Inclusion criteria for the study were being HIV uninfected and pregnant, at least 16 years of age, and attending their first antenatal care visit. We had several primary variables of interest. The first was hazardous alcohol use, which was measured using the audit C, with a score of 3 or higher being considered hazardous use. We also asked about any alcohol use in the past year prior to pregnancy, as well as alcohol use during pregnancy. Finally, we looked at HIV sexual risk, which was measured using a composite measure, which included 4 variables. The 4 risk factors we included in this measure were the presence of a current STI, which was measured using point of care testing. And we looked for the presence of chlamydia, gonorrhea, and trichomonas. And then we also asked for self-report of multiple recent sexual partnerships, self-report of partner HIV serostatus, and self-report of condomless sex at last sex. In order to determine the best alcohol use measure to use for our main analysis, we performed a sensitivity analysis and we consulted the existing literature. Self-reported alcohol use is a subjective measure, and it's therefore subject to bias and underreporting. And this may be exacerbated during pregnancy when alcohol use is stigmatized. Prior research has found that self-report of alcohol use prior to pregnancy is actually a good predictor of alcohol use during pregnancy. It's also worth noting that in our sample, the median gestational age at first ANC visit was 21 weeks, which is well into the 5th month of pregnancy. Therefore, self-report of alcohol use prior to pregnancy may include alcohol use during the first trimester when women were unaware they were pregnant. And the first trimester is a critical period for fetal development. For these reasons, we utilized a self-report of alcohol use prior to pregnancy for our main analysis. We took our HIV sexual risk variable, which was an ordinal count variable, and we dichotomized it into a binary measure, categorizing people as being at high risk or not at high risk. We then presented the results using a cutoff as 2 or more risk factors for high risk, as well as 3 or more risk factors for the high risk category. Multiple logistic regression models examine the association between alcohol use and HIV risk. These models were adjusted for confounders we identified a priori using directed acyclic graphs. The median age of participants in our sample was 26.6 years. And as I already stated, the median gestational age at first visit was 21 weeks. Half of the sample reported alcohol use prior to pregnancy, and 2/3 of those reporting alcohol use had audit C scores indicative of hazardous drinking. 6% of our sample reported alcohol use during pregnancy, and 1/3 of those individuals had audit C scores indicative of hazardous use. 3 in 10 women currently had an STI, and nearly 1/4 had a partner of positive or unknown HIV status. 3% reported multiple partners, while 88% reported not using a condom at last sex. We also looked at bivariate analysis to compare key sociodemographic and behavioral characteristics by those who reported alcohol use prior to pregnancy and those that did not. Persons reporting alcohol use prior to pregnancy were younger, less likely to feel the timing of their pregnancy was good, less likely to report wanting to have the baby, more likely to report having a partner of unknown serostatus, more likely to report recent instances of partner violence, and more likely to report having multiple recent sexual partners. If you look on the right hand of this slide, you can see the proportion of individuals who fell into each category for number of risk factors for HIV sexual risk. As you can see, more than half of the sample had at least one risk factor, while more than a third had at least two. 7.8% had three or more risk factors. The figure on the left presents the unadjusted and adjusted analyses of associations between any alcohol use before pregnancy and HIV sexual risk. Our adjusted models were adjusted for age, education level, employment status, residence type, and current sexual partner. The top two bars show the odds ratios and confidence intervals using the cutoff of two or more risk factors, while the bottom two present the odds ratio and confidence intervals for three or more risk factor cutoff. As you can see in the unadjusted and adjusted models, alcohol use prior to pregnancy was associated with increased odds of being in the high sexual risk category. In our sample, we had a high prevalence of alcohol use reported prior to pregnancy. However, the prevalence of alcohol use reported in our sample during pregnancy was lower than expected based on prior work. So a recent meta-analysis was performed for all of sub-Saharan Africa to try and get point estimates for the prevalence of alcohol use in different countries. And the estimate from South Africa in that meta-analysis is 24%, which is 4 times higher than the 6% in our sample. As I talked about a couple slides ago, self-reported alcohol use is a subjective measure and it's subject to bias. So it is possible that alcohol use during pregnancy in our sample was underreported. In our study, alcohol use was associated with being at high risk of HIV acquisition, and nearly a quarter of individuals had a partner whose HIV status was unknown or positive, which underscores the importance of PrEP use in this population, as well as methods to try and improve partner testing. Evidence-based interventions to address alcohol use and other HIV risk behaviors during pregnancy are urgently needed in South Africa. I was involved in a team that recently conducted 2 systematic reviews looking at psychosocial interventions to address alcohol use in sub-Saharan Africa. Across these 2 systematic reviews, we identified a total of 2 interventions that targeted pregnant women. Both of them were conducted in South Africa. The first was a brief intervention, which reduced mean audit score immediately after the intervention, but did not report outcomes in the postpartum period, which are also important because alcohol use during breastfeeding can also have adverse health outcomes. The second intervention was a peer-led mentor-mother intervention that provided a maternal care package, which included a single session on alcohol use. This intervention followed women well after the postpartum period. I think it was up to 5 years. And they did report an increase in abstinence, but they didn't see a difference between the intervention arm and control arm until 5 years postpartum. So there wasn't a difference during the critical periods of pregnancy and breastfeeding. The fact that only 2 interventions were identified in these reviews really underscores the need for additional work in this area. We also identified a number of additional modifiable HIV risk factors, including the need to increase partner testing for HIV, ensure PrEP offering counseling, test for STIs, and also counseling around STI results disclosure to partners to reduce the risk of reinfection. Future work should focus on the use of objective measures of alcohol use, such as PEth or ETG, as well as self-reported measures that collect alcohol use in real time, such as ecological monetary assessments or daily diaries. These approaches reduce the risk of bias for recall and social desirability. In addition, qualitative work is needed to explore the community norms and attitudes around alcohol use during pregnancy in this setting. The history in South Africa is complex, and it's important that we understand what drives alcohol use in this setting among pregnant women in order to develop a culturally tailored intervention that can address this issue in this population. As with all research, the study had limitations. This analysis uses baseline data, so therefore it was cross-sectional and precludes our ability to infer directionality or temporality between our observed associations. In addition, we relied on self-reported and therefore subjective alcohol use measures. And I've just included my email address on this slide. I would be happy to touch base with anyone after this to discuss this presentation further, or also if anybody has any questions about my personal professional journey. Okay, thank you.
Great. Well, thanks. And I just learned we have